discussing the healthy postpartum period. This is really a fun and exciting time to help families through this transition as they welcome a new family member into their family. We'll be talking about the physical implications of postpartum as well as the psychological implications. In this lecture, we'll first discuss the physical and psychological adaptations a postpartum client goes through. Then we'll discuss the nursing assessment and interventions related to those. There are many physical adaptations that take place after having a baby. Certainly, the reproductive system is one of those. Uterine involution. This is the process of the uterus returning to the pre-pregnant state, or about the pre-pregnant state. Prior to having a baby, the uterus is about the size of a pair of fists and sits very low in the pelvis. It takes about 6 weeks for the uterus to return to the pre-pregnancy state. At about 3 weeks, the uterine muscle itself is healing pretty well, but the actual process of involution, fully returning to where it will be, takes about 6 weeks. And this process of going from, term, the uterus is right under the breast, to about the size of a pair or fist, takes about 6 weeks and is called involution. The placental site, the site where the placenta was. If you remember, the placenta is the organ that allows fetal blood to come to one side, maternal blood comes to the other. There's an exchange of oxygen and nutrients for waste. When that placenta lets go, when that organ lets go, there's a wound left behind that needs to heal. The placental site takes about 6 weeks also to completely heal. What about the return of menstruation? Well, this is really variable. In general, if a woman's not breastfeeding, she should expect to see a period within 6 to 10 weeks. If she is nursing, though, many times her period is delayed while she is nursing, or at least until she starts to introduce solid foods. Here's a great question. The woman hasn't had a period. She's not ovulating during this time. Can she still get pregnant if she's not yet had a period? You know what we call this form of birth control? Pregnant. Many women are anovulatory for their first cycle. However, if they ovulate and have not yet had a period, they can get pregnant during this time. So it is best to be using some birth control even if they have not been having a period. Lactation, or the production of breast milk, is another physical adaptation after having a baby. The initial milk is called colostrum. We call this liquid gold. This starts to be produced as the woman is pregnant, even before the baby is born. Her actual milk may come in 3 to 5 days postpartum, so we may or may not see her in the hospital with her milk actually in. She may have colostrum for that whole period of time. Typically, women are in the hospital 2 days for a vaginal delivery, 3 to 4 days for a C-section, so we may or may not see their milk coming in. Will a woman who is not breastfeeding produce breast milk? Her milk still may come in, so we still may see some breast changes and be prepared to educate her about those. The GI system is also affected. Many women may have decreased bowel sounds after delivery. Certainly if they're a cesarean section, it's an open abdominal kind of surgery, they may have decreased bowel sounds, or from the process and slowing of peristalsis from delivery itself. So we need to monitor them for distension. In addition, many patients have anxiety about having a bowel movement after a baby. If there's perineal or vaginal trauma, if they've had an episiotomy or a laceration to their bottom, they may have anxiety about pain associated with having a bowel movement, or kind of bearing down with that pressure there, and potentially edema or bruising. So we do need to provide them with a stool softener if it's ordered and the patient desires one. The urinary tract will also be affected by the postpartum period. Urinary output normally increases due to postpartum diuresis by 2,000 to 3,000 mLs. So this is quite a bit. Women will be saying, I feel like I'm getting up to urinate all the time. So we have that diuresis going on in combination with fluids during labor and the use of Pitocin, which increases urinary frequency afterwards. However, she may have difficulty voiding because of edema in the perineal area, especially if she was a vaginal delivery. We need to monitor her for signs and symptoms of a urinary tract infection, particularly because we do straight cath them frequently to empty their bladders, especially if they've had an epidural. In addition, it can be difficult to see if she has any blood in her urine because she also has the vaginal bleeding or lochia, but we do need to monitor for this. The maternal heart is also going through changes within the postpartum period. Cardiac output generally stabilizes within the first hour. Now remember, during labor and delivery, cardiac output was increased. It was increased because she was working hard and there was blood flowing to the placenta. Postpartum, there's initially hypervolemia because there's excess blood flow that's no longer going to the placenta. This also acts as a protective mechanism, though. Why might she need extra blood? Because she's had blood loss associated with the delivery, so this acts as a protective mechanism. Postpartum diuresis corrects this, so this gets rid of some of the extra volume through the diuresing in the postpartum period. Lab values can also be affected by the postpartum period following delivery. Initially, hemoglobin and hematocrit can be difficult to interpret. What is the average EBL? EBL stands for estimated blood loss. For a vaginal delivery, it's between 200 and 500 mLs or cc's. For a cesarean section, it's about 1,000. However, there was that hemoconcentration, and the body's still adjusting to the estimated blood loss, so it's very difficult to initially interpret what's going on with the hemoglobin and hematocrit. White blood cells may initially be elevated because of the stress associated with labor. And platelets may initially decrease because the placenta has given away, so there are some platelets being used up there. So lab values can certainly have some changes in the initial postpartum period following labor and delivery. What are normal vital signs during the postpartum period? Many women have normal vital signs. However, some have slight variations. It's normal for a temperature to be up to 38 degrees Celsius during the first 24 hours. However, after the first 24 hours, they should be afebrile. What might a fever indicate? A fever may indicate infection. As far as blood pressure is concerned, it may be normal to have a slightly elevated blood pressure. We'd be concerned if a patient started bottoming out her blood pressure. What might this indicate? This could indicate hypovolemia or hemorrhage. As far as a pulse is concerned, what might be normal? We may see slightly decreased pulse. If a patient is tachycardic, what would you be concerned about? Again, potentially blood loss here. The most common neurological change in the postpartum period is a headache. About 40% of postpartum women experience headaches. We as nurses need to help determine what is causing the headache. They can be caused by fluid shifts associated from the delivery. They can also be associated with hypertension. As high blood pressure, that pressure pounds on the brain and intracranial pressure, the woman can have a headache. Also, if she had a spinal or epidural, she may have a headache from that. As they tap in to the spine or epidural area, they can release some of the spinal fluid, which cushions the brain. If some of that is released or leaks out, there's less cushion around the brain, and this can cause a spinal headache. In the postpartum period, many women lose weight. Initially, the infant, placenta, and amniotic fluid account for 10 to 12 pounds of weight that is lost. In addition, we have the postpartum diuresis. This accounts for an additional 5 pounds of weight that will be lost. Most women, if they gain the average of 25 to 30 pounds that we would expect if they're of average weight, will lose this weight by 6 to 8 weeks postpartum. An exercise regimen can be reestablished once a patient has seen their doctor for their follow-up postpartum visit. This is typically between 4 and 8 weeks postpartum. After pains are uterine contractions or cramping that women experience after having a baby. These are experienced more often by women who are multiparous, women who have had more than one pregnancy and delivery. Why? Because they have lost uterine tone. After pains are also exacerbated by the use of Pitocin. We use this medication for augmentation and induction of labor. We also use it in the postpartum period to make sure that the uterus is nice and firm to put pressure on the placental site where the placenta is let go to help prevent bleeding from that site. Also, women may feel after pains or cramping while they're breastfeeding. Breastfeeding releases oxytocin, the body's natural form of Pitocin from the brain. This is a chemical or hormone responsible for milk production and milk letdown. At the same time, though, it will cause her to cramp. Rubin has also identified the taking in and taking hold periods that a mother would go through. After having a baby, a mother may go through a taking in period where she's very passive. She goes along with the care that's being provided for her, lets others care for her, and has difficulty making some decisions. The book mentions that this can end at around the second day postpartum, where she begins to take hold. She begins to take a more active role. She may be critical of herself during this period, but she is tentative. She requires reassurance during this period that she is doing a good job. She is beginning to take hold of the situation. Rubin also identifies that patients are going through these stages more quickly than they had previously gone through them in the past. Now that you have a good understanding of the physical and psychological adaptations of the postpartum period, we'll be discussing the nursing assessment and interventions. So we've discussed many of the changes a woman goes through in the postpartum period and the physiological adaptations that she goes through. Next, we'll talk about the nursing assessment, and this kind of works hand in hand with what the changes are. So in addition to our normal heart and lungs, vital sign assessment, we'll do a special OB assessment that pertains to some of the changes that she experiences during this postpartum period. In nursing, we love acronyms to help us remember things, and of course we have one for the postpartum assessment. This acronym is BUBBLE-HE, and it moves through the OB assessment head to toe. First, we'll assess the breasts, then the uterus, her bowel and bladder status, her lochia, this is the vaginal drainage after having a baby. We'll assess the episiotomy if she had one, that's the extension of the vaginal opening for delivery, or if she's had any vaginal laceration, we would assess that there. We would assess a Homans, although this is controversial, it is part of the BUBBLE-HE assessment, and many hospitals are still using a Homans sign to detect the possibility of a DVT, or deep vein thrombosis. And then we'll assess her emotional status. We'll talk about each of these in the slides to follow. During the breast assessment, we're assessing two things. They are the consistency of the breast and the intactness of the nipple. We'll talk about consistency of the breast first. We'll assess this whether a mom is breastfeeding or not. Her breast can feel soft, they can be beginning to fill, they can be very firm, or they can be engorged. Engorged means hot, red, shiny. Generally not a good thing to be engorged with milk. We would use ice packs and these kind of things. We'll talk about further interventions for engorgement as we move on to breastfeeding and newborn nutrition. As far as the nipple is concerned, if she's not nursing, her nipple should be intact. If she is nursing, we will assess the nipple to see, is it intact? Hopefully it is. That means that the baby is latching properly. It may be cracked, blistered, or bruised. It shouldn't be any of these things. What does it mean if we see a cracked, blistered, or bruised nipple? It means that the baby isn't latching properly. Breastfeeding should not be painful. However, if the baby isn't latching properly, it can be painful. It should feel like a pulling sensation, but no pinching. And like I said, we'll discuss this further in the newborn nutrition lecture. As far as breast care is concerned, we recommend that patients wear a supportive bra. In addition, if they're breastfeeding, we recommend that they breastfeed on demand. As far as caring for their nipples, if they're sore at all, We recommend that they use products that are made for the breast. So lanolin cream, there are also hydrogel dressings that would be used sort of like a wound care dressing. Again, we ask them to avoid strong smelling perfumes or lotions as the breast tissue can absorb this. If they're not voiding, we ask that they avoid breast or nipple stimulation. An example would be if they're showering to face their back to the shower rather than facing their chest to the shower. They can also use ice packs. We will also assess the woman's uterus. We'll have the client void prior to the assessment because the bladder can displace the uterus, and we'll put the head of the bed flat. This allows us to more easily feel the uterus. We'll assess two things here also: the location of the uterus and the consistency. The location is assessed in relation to the umbilicus, or the belly button. Where is it in relation to that? After delivery, we expect it to be somewhere around the umbilicus. The consistency. Is it firm or is it boggy? So we're feeling the fundus, the top of the uterus. We want to see that it's firm. Like I said, we want to see that that muscle is nice and firm. The uterine muscle, if it's firm, puts pressure on the site where the placenta gave way and helps prevent bleeding there. What does a boggy uterus mean? A boggy uterus means that it's spongy. It's not firm. There's not good uterine tone there. Sometimes we'll call that atony. Interventions for a boggy uterus: if you massage the uterus and feel that it's spongy, we would massage it. Certainly, if there's no pressure on that uterine muscle, there's no pressure on that placental site, so we're going to need to monitor for bleeding, and that would be coming from the vagina. It would be coming from the placental site, leaking through the uterus out of the vagina. Also, vital signs with this. If she's bleeding and bleeding heavily, what do you expect vital signs might be? To compensate, she might be tachycardic, and she might have low blood pressure. Also, what about her level of consciousness? We want to make sure that she's still A&O times 3. We also need to call for help if we find that she's in a hemorrhage kind of situation. So for a boggy uterus, we'll massage the uterus, monitor bleeding, vital signs, level of consciousness, and call for help. This is a great picture that helps demonstrate how we assess the uterus. So you want to support the uterus. That means put the hand below the uterus. We don't want to prolapse her uterus or inadvertently push it out, is what it would mean to prolapse it. So support the uterus at the base of the uterus, and then palpate the fundus, the top of the uterus. We're going to assess the location, like I said, in relation to the umbilicus, and we're going to assess the consistency. Again, ideally, we're hoping to see a nice, firm fundus. It almost feels like the ridge of a hard apple. And in this picture, you'll see that the head of the bed is flat, and that will help better assess the uterus. As I said, we measure the uterine location as it relates to the umbilicus. We do this in finger breaths above or below. So if it's at the umbilicus, we would say at the U or at the umbilicus. If it's one finger above it, we would say +1, or 2 fingers above it, +2. Here in this picture, we see below it. So 1 finger below, -1. 2 fingers below, -2. 3 fingers below, -3. The location of the uterus, as it goes down and returns to the pre-pregnancy state, this is called involution, as I've mentioned before. When assessing the bowel and bladder, it's good to ask the patient when she had her last bowel movement. Now, sometimes the contents of the bowel can be evacuated during delivery. It's not uncommon for a woman to have a bowel movement while she is pushing. Some women also have diarrhea prior to going into labor. So it's important to ask when she had her last bowel movement. Also, is she passing gas? That'll tell us if peristalsis is returning. We'll also assess for bowel sounds, and if she has an order for a stool softener and she's afraid to have a bowel movement, we might want to ask her if she'd consider taking that. As far as the bladder is concerned, a couple of things here. You'll remember that she has the diuresis of the postpartum state, so we will expect her to be urinating frequently. We are also going to assess for signs and symptoms of urinary tract infection. These would include frequency, urgency, burning upon urination. As I mentioned, we often straight cath patients every 2 hours to empty their bladders if they have an epidural, since they don't have the sensation or ability to urinate on their own. This puts the postpartum client at risk for urinary tract infection. Next, we'll assess the lochia, or the vaginal drainage following a delivery. Where does lochia come from after a delivery? This is a good question. Where the placenta lets go, there's a wound left behind in the uterus, and some bleeding can come from there. What is lochia composed of? It's composed of epithelial cells, erythrocytes, bacteria, occasionally some fetal meconium and lanugo also. So here's a question. If some of it's coming from the placental site, do C-section deliveries have lochia, assuming they had no vaginal trauma? Well, we know that the source of lochia isn't just from vaginal trauma of a delivery. A major source is that site where the placenta was. So a C-section delivery did have a placenta that was delivered, so they will have lochia. We assess color and amount. When we assess color, we expect it to be rubra or red for the first 2 to 3 days. Next, we'll see the color change to serosa or pink as kind of some cervical mucus is mixed with it. This would be for days 3 through 10 following delivery. After serosa, we expect it to become alba, or kind of a clear whitish yellow color, and this will last 1 to 2 weeks postpartum. In addition to assessing the color of the lochia, it's also important to assess the amount. This can be scant, light, moderate, or heavy. The question is, how much is too much? If she's saturating more than a pad in an hour, or having clots that are bigger than the size of a plum or an egg, there would be room for concern. We'd probably want to make sure that her uterus was nice and firm. If her uterus is firm and she's still bleeding bright red blood, she may have a cervical laceration. So we do need to assess what's going on here in relation to her bleeding. Now it's important to ask one other thing. If you look at a pad that's saturated, what do you need to know before you're concerned about that? What do you need to ask her? You need to ask her when she last changed it. Maybe she slept all night, and you're coming in to do your first shift assessment at 7:30 in the morning and her pad is full. Well, if she last got up to urinate and change her pad 8 hours ago, a full pad of lochia is a very different assessment finding than if you asked her and she said, oh, it was a half an hour ago. So more than a pad an hour is too much. Now that we've assessed her lochia, we will assess her perineum if she was a vaginal delivery. The best way to do this is to have the patient turn on to her side to assess her perineum for intactness. If we just have her assume the lithotomy position in a bed, it's kind of difficult to see in between the labia. The area where we're trying to see is the opening between the vagina and the rectal area. So having her turn on to her side and kind of lifting the buttock up to see that area is the best way to visualize this. What are we looking for? If she had an episiotomy, which would be a surgical incision to open the vaginal opening a little bit further, or if she had a laceration where the skin tears a little bit, we are assessing that area for RETA. Again, another great nursing acronym. We are assessing redness, edema, which is swelling, ecchymosis, which is bruising, any purulent drainage that's coming out, and how well approximated the area is. We're going to note edema, ecchymosis, hemorrhoids, the presence of purulent drainage, separation of any sutures that are there. Typically, just FYI, the sutures that are used if there does need to be a repair are made of chromic gut, so they're self-dissolving sutures. As far as perineal care is concerned, we ask patients to change their pad every time they void and as needed. This is good hygiene and helps avoid infection. In addition, we'll give them a peri bottle. This is a small kind of squirt bottle. They can fill this with warm water and gently rinse off their perineal area, and they should do this as long as their bleeding continues. They should avoid the use of tampons as these can help collect bacterial growth, so they should use pads while they're bleeding after having a baby. They can use ice packs for comfort and to help decrease swelling. In addition, the picture here shows a sitz bath. A sitz bath is kind of some warm water that swirls around. The purpose of this is to increase blood flow to the perineal area to help aid in healing. It can also be soothing and does a little bit of cleansing at the same time. If she was a cesarean section delivery, rather than checking her perineum for intactness, we will be checking her surgical incision. Most of the time, this will be a low transverse abdominal incision. What will we check? The same thing, Rita. We will be checking her abdominal incision for redness, edema, ecchymosis, the presence of drainage, how well approximated it is. She may have staples or steri strips, and we will also be making sure that those are intact. We answered this question already. Do C-section clients still have vaginal bleeding or lochia? The answer is yes, they do. They still have the uterine debris and they still have the placental site that can be bleeding. So we would still check a lochial assessment on them as well. It's important to assess the mother's emotional status and educate her about the possibility of postpartum blues. Postpartum blues are a transient period of depression. This may start in the hospital or 2 or 3 days postpartum and typically lasts until about 10 to 14 days postpartum, so it is transient and fairly short term. It's characterized by mood swings, some weepiness, or anger. It may be due to hormones, and also patients who lack social support systems are at higher risk. There are several tools that we can also use to evaluate this. It's very important that a patient has a support system. If she goes home and feels that her depression is lasting longer, then, kind of the 14-day window, if she starts having irrational behavior, that's not within the scope of postpartum blues. If she starts feeling like she's going to hurt herself or hurt the baby, that's not a normal part of postpartum blues. Having a support system, somebody she can call if things start to get worse, is critical. This can be a significant other, a family member, a friend, neighbor, or a care provider. But we definitely want to make sure that she can identify a support system before she goes home. A woman who has a history of depression is also at higher risk for postpartum blues. As we assess the psychological adaptation, an important consideration is bonding between the parents and the newborn. A good way to assess bonding is to look to see if the parents are caring for the baby. Are they looking to see that the baby's needs are met? Are they changing the diaper? Are they feeding the baby? Are they interested in talking to the baby and consoling the baby? If the baby cries, are they attempting to settle the baby, making sure that it has everything that it needs, swaddling it, trying to soothe it, talking to it in a loving manner? Assuming an end-face position, the book speaks of this. End-face position is where the mother or father would hold the baby closely and have eye-to-eye contact with the baby while the baby is awake. Also, parents who are effectively bonding tend to ask pertinent questions about the baby and how to care for it. As it pertains to the father, the book uses the term engrossment, and this means that the father is very absorbed in the baby, he's preoccupied and interested in the infant. Another measure that supports bonding and family attachment that's supported by evidence-based practice is skin-to-skin contact. Oftentimes we support this in breastfeeding. Breastfeeding can certainly be a time when bonding can take place between the mother and the newborn. Skin-to-skin contact is just that. We put the baby's skin directly on the parent's skin. As you can see in the picture, both parents can do this. This is a great opportunity to engage both mothers and fathers in bonding with their newborns through skin-to-skin contact. Let's consider some common medications that are ordered for our postpartum clients. They include Pitocin. This is the same medication that we use for labor induction and augmentation. In this case, we're using postpartum Pitocin to make sure that the uterus is nice and firm. In the case of a vaginally delivering client, They'll typically run one bag in and then discontinue it. In the case of a cesarean client, they'll run this typically until the next morning, so between 12 and 24 hours following her C-section. Also, many times stool softeners are ordered in case the patient is having a hard time having a bowel movement or is fearing having a bowel movement because of her perineal trauma due to the delivery. A big one in postpartum are pain medications. Big sites for pain would be abdominal cramping, perineal pain, incisional pain. Common pain meds that might be ordered include ibuprofen or Tylenol, Percocet, or Vicodin. Tylenol and Percocet. Percocet does contain Tylenol. What organ are Tylenol and Percocet toxic to? The answer is the liver. In addition, if a patient is rubella non-immune during their prenatal labs, they will have a rubella vaccine ordered for them prior to being discharged from the hospital. It's important to note that a patient should not get pregnant for 1 month following administration of the rubella vaccine because it can cause birth defects on that pregnancy. Also, RhoGAM might be ordered. RhoGAM would be ordered if a patient is Rh negative. That is, if her blood type is A negative, B negative, AB negative, or O negative. We'll be discussing the implications of a mother who's Rh negative in further lectures. Nurses have a great opportunity to teach postpartum patients. As far as teaching self-care is concerned, we will educate patients and encourage them to practice hygiene that will prevent infections such as pericare. In addition, if they are not going to breastfeed, we can encourage them to use ice packs, place these in the axilla area. Sitz baths, as I mentioned, to promote circulation and healing. We can often send these home. Many hospitals have disposable sitz baths that the patient can place in their toilet at home and use also. They can also use ice packs to the perineum for comfort. Again, nothing per vagina. This means no tampons or douches. At the same time, we should encourage patients to abstain from sexual intercourse for as long as their bleeding lasts. Where the placenta let go, that site is a great source for infection. If they're having intercourse, the glucose in the semen, the dark, warm environment, this is a setup for infection. So as long as they have bleeding, they should not be having sexual intercourse, and they should abstain from sex until they go to their postpartum visit, which is typically between 4 and 8 weeks postpartum. We should also talk to patients about birth control options. They'll also be talking to their provider about this. What are their plans for birth control now? It's also important that patients know when they should contact their provider. If they have sore or red breasts, this could be a sign of mastitis, so they should call. In addition, if they're saturating more than 1 pad an hour, this would be a sign that she could be hemorrhaging or have another problem going on, so she should contact her provider in this case. She may also notice that with increased activity, she may have more bleeding, so her body will tell her if she's doing too much. If she's having any purulent or foul-smelling vaginal drainage, if she's having urgency, pain, or bleeding upon urination. If she's having a headache, chest pain, shortness of breath, or visual changes, these could be signs of high blood pressure and she should contact her provider. C-section patients, if their incision is reddened, if it's edematous or draining, if she's noticing that it's opening, it's not well approximated, she should call. If she has a fever, there could be a source of infection somewhere. This would be another reason she would call. If she's depressed or feeling the blues longer than kind of the 10 to 14 day normal time period, if she's thinking about hurting herself or the baby, she should definitely call her provider. I always wrap up and tell patients if they have any questions or concerns, they should not hesitate to call. This concludes the Healthy Postpartum lecture. If you have any questions, I'd love to hear from you.